Thank you everyone for joining us today for our talk called Moving the Needle on HIV Prevention with Behavioral Economics. Go next slide. My name is Mary Andrews, and I'm a health communication PhD student at the University of Pennsylvania. Dan Resnick is a med student at University of Pennsylvania, but he has taken some time off to pursue a master's in health policy. And Deborah Cousins is also a student here at University of Pennsylvania. And she, in addition to that, she works full-time as a project manager in medical ethics and health policy research. And also before I also wanted to mention just kind of more like how we all connected. So we all took a class together called Behavioral Economics and Health, taught by Allison Buttenheim, where we worked on a group project designing an HIV prevention intervention using a behavioral economics framework. So we're not experts in this, but we wanted to share what we learned about behavioral economics with the HIV prevention world. Next slide. So I'm going to introduce what behavioral economics is. Then Dan will go into behavioral economics and HIV. And at the end, Deborah will talk about potential strategies that you can incorporate behavioral economics into your own everyday life and also into clinical care. And she'll also present a little bit about the interventions we came up together in class. That's about more HIV prevention things. And also, just like before we move on, I wanted to say that we share the pain of the other epidemic that's been happening for a long time, but is especially salient now, which is police brutality against Black people. So we're so grateful for everyone that was able to join us today. But we also just wanted to make a statement that we stand for everyone that couldn't be here because they're out there protesting or fighting racial injustice in other ways. Okay, move on. And as our moderator mentioned, we initially wanted this workshop to have a lively discussion and to share things we learned in class outside of the classroom with the community. So in lieu of this face-to-face discussion, we decided to add a few polls to keep the workshop engaging using Poll Everywhere, which is a free software compatible with these slides. So to participate, you can text Dan Resnick, which is highlighted in the red box, so DANRESNICK 320 to this number 37607. If you want to participate in the polls later, the first poll will be on the next slide. But I'm just going to leave it on here for a few seconds just so everyone can sort of join in. And then once you've done this initial texting, when you see a poll, you can just respond with your poll answer. You don't have to redo this. All right. Also, this message will be displayed above the polls too, so I think we can move on, and if people weren't quite ready, this number and code should show up on the next slide with the poll. Right. So yeah, the first thing we just wanted to see who's watching this, who's here. So just respond to, again, if you missed it in the first step, you text, just text your response of whichever category you fit in here to 37607 after you've typed in the code Dan Resnick. So, okay, well, this is so exciting. I'm really glad this worked, and also that we have such a mix of different participants here. We can, I guess we can move on to the next one now, but good to know that seems there's definitely a diverse crowd, and we hope that we can share something useful with you all. All right, so now, as I said before, I'm going to give a brief introduction about what behavioral economics is, especially in the context of health. Go to the next one. So another fun poll before I start talking. I kind of just want everyone to send 1 to 3 words about what they think behavioral economics means, and send it to the same number that you responded to the poll earlier. This is fun to watch. See, this, for people who don't know, this is like a word cloud. So the words get bigger the more people say them. So it's like weighted more heavily. But good mix. Well, like at the end, we are going to save this. We can see what everyone's initial thoughts were, but it looks like everyone is pretty close to being on the mark. You'll leave it for a few more seconds to see if any changes happen. Cool. Seems like money is the big one. Like anything with economics always goes to money. All right, I think we can go on to the actual definition. So, as I said, a lot of like what you sent in was definitely on the mark. The official definition is that it's the intersection of psychology and economics that investigates what happens when agents, meaning people, display human limitations and complications in making choices and allocating resources. So this definition was difficult for me to understand at first. And in other words, it means, well, I guess the field of behavioral economics started when some economists realized that people don't always make decisions by effectively weighing cost and benefits of each option available to them in a straightforward, logical manner. In reality, people can be easily distracted or emotional, and we don't always make decisions that are in our best interest. So behavioral economics tries to leverage those kinds of barriers, which I would not really call human limitations, but rather things that make us human, to help make the decision-making process smoother. Next slide. So some key barriers to for humans to make decision-making is that we have bounded rationality, meaning we experience limits in formulating and solving complex problems in receiving, storing, and retrieving and transmitting information. We also have limited cognitive processing power and attention, so we can't fully pay attention to every piece of information at once that might help us lead to a more informed decision that's the best decision for us. We also, of course, just have limited self-control, and most of the time we're presented with imperfect or incomplete or even just overwhelming information. So we can't take that all in to try and make a solidly rational decision where we weigh the cost and benefits of what's in front of us. Next slide. So some ways that we've adapted to these barriers that are innately human are by cognitive biases and heuristics, which are mental shortcuts or processing aids to make decision-making easier. And some common ones that we'll talk about more detail later, but the ones that I like a lot are hot-cold empathy gap, which means people underestimate the influences of visceral drives on their own attitudes and behaviors. So for example, when someone is in a cold state, they may plan on never having sex if they don't have a condom with them. But in a hot or aroused state, they might still have sex even if they didn't have a condom on them because they didn't really anticipate how they would feel in a certain moment. Another common one is present bias, which is the tendency to settle for a smaller present reward, like smoking a cigarette, rather than waiting for the larger future reward of not getting cancer. And optimism bias is when people tend to overestimate the probability of positive events and underestimate the probability of negative events happening to them in the future. So for example, most people underestimate the chance that they personally could get cancer. And planning fallacy is the misprediction of how much time we'll need to complete a future task. Hassle factors refers to anything that prevents us from doing our work efficiently and effectively. So something in the health context could be, but that's a hassle factor, could be trying to take off time from work to get to a doctor's appointment. And salience is paying attention to what is particularly noticeable, important in the moment. So it's kind of like whatever stands out to you is usually what we will focus our attention on. And I'm sure all of you can think of examples of when you've used these mental shortcuts in your own everyday life. Later on, Deborah is going to ask you to try to relate these to your own life, or if you work with patients into clinical care. So feel free to start thinking of these examples as the presentation goes on. And these cognitive biases I mentioned are they can lead to bad or suboptimal or irrational decisions. But when we apply a behavioral economics framework, they can be harnessed to design a more effective public health intervention. Now, next slide. So there are several effective behavioral economic frameworks out there. And one good example is the EAST framework, which the behavioral insights team in the UK used to try use this EAST framework to harness cognitive biasing heuristics when they design effective behavioral change interventions. So when they're thinking of large scale interventions, they always try to make them easy, attractive, social, and timely. All right, next slide. And so nudge is a word that behavioral scientists often use to describe making it easier for someone to make a healthy decision. So for example, like the text messages I get from my university's health center that remind me about my upcoming appointment the next day nudges me to attend that appointment when it's scheduled. So this behavioral economic framework was a clever play on words that refers to narrowing down a big public health problem like HIV to a specific population and behavior to focus on. Then the next step is understanding how and why the population of interest engages in the behavior of interest. So the behavior of interest could either be something like preventative, like trying to get people to adhere to taking the preventative HIV drug PrEP, or it could be like trying to get people to stop doing a behavior like to stop smoking. And then the next step is discovering which cognitive biases and heuristics contribute to the barriers of engaging in that behavior. And from all of that information, you then generate interventions to try to address those barriers and make it easier for people to make healthier decisions. Then the last step is evaluating if those interventions actually work and for whom they work. And Deborah will touch on a project we did in class where we followed this nudge framework. Okay. And before I pass this presentation on to Dan and the introduction, I wanted to make a disclaimer that behavioral economics is not a substitute for necessary structural change that needs to happen for a lot of health interventions. So something like a structural barrier is aspects of the external environment that limit one's ability to make healthy choices. So for example, if you're not able to walk to a grocery store, that's a structural barrier. And maybe behavioral economics can make it easier for you to find ways to get to one. But in essence, a big structural change of how neighborhoods are set up in certain areas needs to change for that, something like that to change. So just want to keep that in mind when it's not a solve all, there needs to be a lot more policy and a lot big structural changes to actually improve HIV prevention. Right, and that was the end of the introduction.
Thanks, Mary. Hi everyone. As a quick reminder, my name is Dan. I'm a medical student and health policy student at the University of Pennsylvania. And for this part of the presentation, we're going to talk a bit about how to use a behavioral economics framework to examine some HIV prevention interventions. And kind of a couple goals to have in mind. First, we will start where Mary left us off and kind of tease apart these structural barriers and individual barriers from one another, specifically using the PrEP care continuum. We'll also use insights from behavioral economics to understand these individual barriers better, and finally look at a couple of the newer PrEP modalities through a behavioral economic lens. And I wanted to make a couple important caveats here, especially about this part of the presentation. One, that it's very PrEP focused, and we really don't want to suggest that PrEP is the only way or even the best way for any given person to prevent themselves from acquiring HIV. The examples we'll use are also predominantly focused around men who have sex with men. And again, we're not trying to suggest that this is the only group or the most vulnerable group to HIV. And certainly behavioral economics may be used in many other contexts. We just wanted to keep this focused as much as possible. And to achieve our objectives, we'll use this fictional case of JD. And JD is not a particular person per se, but really he could represent any of us as we grapple with our own healthy habits. So in this context, we're JD's PrEP providers, and we're seeing him for his regular 3-month appointment. But during this appointment, JD's interested in potentially stopping PrEP. He specifically tells us that since the start of the COVID pandemic, he's really only seen one other partner, and it's hard for him to remember to bring his PrEP medication over to his partner's place when he stays over a couple times a week. He's also not really sure, now that he's mainly monogamous with this one person, if he's even high risk enough to be taking PrEP every day. Though he does say that he's had one sexual encounter with an ex of his over the past 2 months, and he's not really sure if his main partner is completely monogamous either. Now, some of you might be thinking that JD should definitely stay on PrEP. Some of you might think that it's appropriate for him to stop. And the goal here isn't actually to tease apart that decision, but to better understand from a behavioral economics lens why JD might be having these thoughts and challenges, these thoughts about stopping PrEP and these challenges to adhering to PrEP. And if ultimately JD decides that staying on PrEP is in his best interests, behavioral economics also has some possible solutions to offer to make his life a little bit easier. So as we look at these steps in the PrEP care cascade that kind of list out what someone needs to do to get to the point of taking a pill every day. First, let's acknowledge that JD jumped through a whole number of hoops just to get to the point of taking pills every day. And now his main struggle might be adherence. Northwestern's PrEP cascade lists these various steps to reach PrEP adherence. And they would start from really learning about PrEP all the way to taking this pill every day. Each of these steps requires both individual and societal actions. While an individual needs to perceive himself to be a good candidate and attend the necessary appointments, society also needs to make sure that there are enough providers in the area and that the medication is affordable enough for anyone that needs it. In other words, while some of the challenges of getting through this cascade are due to the kind of being human, as Mary suggested, some of the other challenges lie at the social, political, and economical level. And the reason this is important is differentiating these challenges can help guide us when and which behavioral economics would be most appropriate in a given situation. It can also clue us into situations in which behavioral economics might have to take a back seat. For example, many of you know that southern states in the US account for 60% of new HIV diagnoses and only 30% of PrEP prescriptions. And why that's the case? Well, many people point to lower rates of health insurance due to not expanding Medicaid, fewer trained PrEP providers in the area, and higher rates of HIV and PrEP stigma in those regions. These are structural issues, and in this scenario, behavioral economic interventions might be helpful on the edges or an augmentation of structural reform, but this isn't a case where behavioral economics will truly move the needle forward without structural reforms. To make this distinction a little bit more specific, I'm hoping to use one of these polls again to do kind of a thought exercise. So I've listed kind of 3 potentially pretty common barriers to initiating and staying on PrEP. And I was wondering if you could help me select basically which one appears to be the most structural on this list. I'll give it a few more seconds. I really appreciate everybody participating. We were worried that this might not work or that we would kind of just be staring at a blank screen. So I really appreciate this. All right, I will move on to the next question, which is kind of the opposite, which of the following barriers appears to be kind of more individual in nature? Awesome. And really appreciate you participating with this. And I think one of the things that the poll showed is that these are somewhat kind of common sense, but somewhat not actually. And that there are barriers that are kind of both mixed, and certainly there's some individual barriers that might be due to the more societal kind of upstream factors, and there's certain structural barriers that could be overcome with a little bit of different individual action. This is just how I kind of sorted out those 6 barriers that we saw into individual, mixed, and structural. But again, I think there's certainly room to discuss this. And to be honest, like if this were in person, I would have loved to like engage in a much greater back and forth about this. The main takeaway that I kind of wanted to suggest with this is that if someone tells us that their main barrier to initiating and staying on PrEP really lie on the left-hand side here, kind of under what I described as individual. Behavioral economics has a lot of potential solutions to offer for that person, maybe more so compared to barriers that are more in the middle or on the right. So let's take a look at kind of these 2 barriers a little bit deeper. Why did JD struggle to continue taking PrEP once he started spending more time with his partner? So behavioral economics tells us that for a behavior to become a habit or an action that we basically do automatically, the behavior depends on this 3-factor loop. First, we must do the behavior repeatedly. It has to become a routine for us. We have to reward this positive behavior in a certain way, and we need to be in a stable environment that cues us or reminds us to do the behavior we want to do. So for example, if I really want to start going to the gym twice a week, once the gyms reopen, the first thing I have to do is really force myself to go twice a week, repeatedly. When I do go, I also need to find a way to reward myself, hopefully in a healthy way, for actually doing what I intended to do. And I also need to set a certain reminder system, for example, packing my gym bag the night before, that kind of cues me to the fact that this is actually my gym day. And the more I do this and the more I kind of do each of these steps, the more ingrained going to the gym hopefully becomes. And maybe at some point I don't even have to think about Monday and Thursday being my gym days. They just are. So what happened in JD's case? Well, going to his partner's house basically interrupted his habit of taking PrEP. First, he had to create a new routine of bringing the pills with him each time he went to his partner's place. When he was at his partner's place, he might have also lacked the contextual reminder for him to take his PrEP. For example, maybe JD normally stores the PrEP bottle next to the deodorant, so that's his reminder to take the pill each morning. But at his partner's place, maybe the deodorant stays in a to-go bag or a travel bag, and he doesn't have that cue to take PrEP. In fact, when we tell people or talk to people about breaking unhealthy habits, the first thing we do is see if they can remove themselves from situations that cue the unhealthy behavior. And lastly, this issue is kind of compounded by the fact that there's no immediate reward to taking PrEP. One doesn't feel better per se after taking the pill. This makes it harder to reinforce the behavior because all of the benefit is in the future. And this isn't to say that that no person will ever take PrEP. We know that study after study show that plenty of people, young and old, take PrEP very consistently. We just need to keep these factors in mind as we discuss PrEP with patients who are starting it or patients who are saying they're having some issues with adherence. And this is especially true of younger patients who might not have had to take a pill every day, basically in their lives. And how about the fact that JD has a sense that he might be low risk for HIV currently? This is a common reason people give for not initiating PrEP or for discontinuing PrEP once they're on it. And in fact, a kind of potential underestimation of one's risk is a very common phenomenon, and is certainly not specific to HIV. And Mary already introduced some of the behavioral biases behind this. The first thing is this hot-cold empathy gap. When JD is considering his HIV risk on a day-to-day basis, he may be focused on his cold state, in which he has one primary partner. In this cold state, JD might be even making plans about what to do if an ex reaches out to him, knowing that he's not as adherent to PrEP anymore. For example, he might insist on using a condom or avoid having anal sex altogether. But when that message from the ex comes, our present bias kicks in, and the plans that we made during the cold state might no longer be relevant. To use a very different example, this is also why we tell people to go shopping when they're full. Because when we're hungry, and that's kind of our visceral hot state is hunger, we tend to basically crave everything in the store, and we end up buying way more food than we need, and especially junk food. The second thing that makes it hard to predict risk is optimism bias. Some of us are simply more conscious of other people's risks than our own. We think we're better drivers than others, we think we're better doctors than others, and we think that we're more immune to particular disease than others. And lastly, we need to acknowledge that calculating risk is very hard to do, whether it's a risk for catching COVID or a risk dying in an air accident, so on and so forth. People inherently struggle with numbers and probabilities, and calculating risk taxes our limited cognitive and processing power and attention, as Mary was referring to earlier. And we also have imperfect information, and this is especially true, unfortunately, when we know that the HIV disease burden, for example, is unshared equally in society. But now that I kind of talked about now that we kind of deconstructed these individual barriers to taking PrEP every day, what would behavioral economics have to say about newer PrEP modalities? So PrEP on demand is a medication regimen that people take the pill only the day of and 2 days after a sexual encounter, rather than taking the pill every day. If we think back to the EAST framework that Mary presented earlier, PrEP on demand certainly seems timely and attractive. The intervention basically occurs in proximity of the behavior in question. But is it easy? Does the lack of routine and contextual cues potentially wash away the benefit of it being so timely? For some people, the answer might be yes, and for others, it might be no. A similar question arises with a long-acting injectable form of PrEP, which may be on the market in a year or two. Basically, receiving an injection every few months, to me, seems more attractive and easier than taking a pill every day. It also completely takes away the hot-cold empathy gap, because someone is protected no matter what visceral state they're in. But there's some barriers to getting monthly injections. Going to the doctors every 1 to 2 months might be more burdensome for some people than taking a pill every day. And for some people, getting a needle in their arm, again, might be less attractive than taking a pill every day. Basically, there are behavioral barriers and drawbacks to each of these strategies. But the benefit overall of having all these different modalities is that each person might do better with one versus the other. And lastly, because it's kind of on a lot of people's minds, we did want to circle back to COVID and its impact on PrEP adherence. We know many of you have probably been thinking about this and using a little bit of a behavioral economics lens to look at this. So a few things that we thought could be a COVID-related impact. One, we are hearing at least that PrEP discontinuations might be on the rise right now. And these PrEP holidays might be very reasonable for some people as their risk changes. But the big question for us is, how do we keep HIV prevention salient enough for these individuals so they can remember to reinitiate PrEP before they resume more frequent sexual activity? We also know that people's routines and environments have been disrupted by this pandemic. Some people are sheltering in different places, and people's daily schedules have certainly changed. So how can we support patients to establish new routines and new habits in this new environment? And lastly, I think most of us champion the move to more telemedicine appointments and potentially fewer lab visits or more lab at home visits. We need to recognize that even telemedicine has its own hassle factors. So trying to reduce these hassle factors for patients is very important as we move forward. So now I know I presented a lot of kind of a whole bunch of barriers from a behavioral economics perspective. So I'm going to turn to Deborah to talk a little bit more about solutions.
Well, great. Thank you very much, Dan. So it's at this stage of the presentation that we want to start brainstorming together potential strategies that harness behavioral economics concept we just learned about in parts 1 and 2 of our presentation. So I want to first ask you some questions based on what we've learned today so far. Then I want to share more details about the nudge toolbox that we created during last year's behavioral economics course. And after that, we want to hear your ideas, because actually the goal of this workshop was to come up with our own toolbox that we could take with us and to use at work or in our daily life. So these questions I'm going to ask you, I'm not going to use the same text response. We're actually going to be using the Q&A for some of these questions. So the way this is going to work, I'll read the prompt and give you about 3 minutes or so to answer the question. And then it would be great at this time if the moderator would be willing to read out some of the responses, not all of them, but scan them for some representative responses. It would also be helpful if you could label your response with the number 3A so that she can figure out which response goes to which question. Mary and Dan, please be sure to answer as well. And also to the moderator, please feel free to answer as well. So Dan, gives you the next screen to show the question. Okay, question 3A. In general, how have you used behavioral economics concepts in your field or your daily life? So you're using the Q&A response box below. And I see some coming in, so great, thank you. Maybe do another minute or so, and we'll see if the moderator wants to read us in about a minute. Again, if you could label it a 3A, just so we know that you're not just asking a question, but you're actually responding to the question probe. Okay, maybe wrap it up in a few seconds. Look at your responses in. Great, I see a lot. I think everybody has been using behavioral economics concepts in their own lives, for sure. Great. So Dr. Reeder, would you be able to choose some of these responses?
Sure. So some of the responses that came in, one was mindfulness and intentionality. To try to remember to take my heart meds and depression meds each day, to examine my own behavior when making medical choices, medications, treatments, taking my multivitamins and HTN meds. I have to thoroughly assess clients to different questions. Oh no, that's the answer to 3A. I've had to thoroughly assess clients who are HIV positive who lack consistency with their antivirals. That's their 3A response. To lose weight by different food choices. Put pills in weekly pill box. Prepare gym clothes the night before. Walk dog at the same time. I often use the stages of change model with clients. Remembering to take pill every day. And that's all the responses to that question.
Oh, great. I mean, I think those are excellent examples, and I feel that we've all used these concepts in our daily life or at work, and so I'm really happy to get those responses back. So I feel like this makes sense to everybody. I have another question for you if you want to go to the next slide. Sure. So again, this is 3B, and I'm going to give you 3 minutes to answer. What are some of the biggest behavioral and structural barriers you've encountered with respect to HIV prevention? So this question actually is related to HIV prevention. And I know not everybody will come to this workshop with experience in HIV prevention, but if you have some experiences, please let us know. Remember, this is behavioral or individual, and then versus structural barriers as well. And this is 3B. Thank you, yes. Great responses so far. So maybe another 30 seconds, and then we'll ask the moderator to read us some responses. Okay. Well, thanks so much. And to the moderator, if you would kindly read us some responses.
I apologize, my computer froze, so I was having a hard time. I'm sorry. Okay, questions. People not being open-minded. It's been a clear Is there a way for me to implement change? Positive 40 years. Well. Okay, my computer is acting up again, and I'm having a hard time.
So I can see them, so should I?
Yeah, do you mind stepping in?
Sure, no problem. I'm going to go scroll up. So they're so good, I want to read them all. One respondent said stigma, consistently using condoms, people that believe they are immune to the virus. Someone said I use my life to help implement change, and other people. Counseling someone who continues with risky behavior by being on Grindr and having sex when HIV positive. Psychological safety. Someone suggested that maybe the limited availability of affordable healthcare is definitely a significant barrier that we come across. Also stigma around HIV prevention, that HIV prevents individuals from taking meds or getting checkups. Adherence to risk reduction plan, whether having condoms attainable or reduced risk sexual pleasures. Denial is a major problem. People in recovery don't see the risk in sharing needles. So lots of ideas, you guys. These are awesome. Agencies that don't want to pay the cost, acknowledgement of risk-taking behaviors, availability as access to caregivers with whom to discuss. So these are great, and I just feel like really happy that everybody provided these examples, and so I think it's really going to help us also understand or either confirm what we learned during our own coursework. So my next question is one more question we have before we move on. So question 3C, have you or your team ever used behavioral concepts, economics concepts for HIV prevention? And this is sort of like at work or what are you actually doing related to HIV prevention? The last question was about barriers, and so this question is about where do you think you're using these concepts already in your daily life or at work? This is 3C. So again, I'll give you like 2 to 3 minutes. You guys are pretty fast, so you may not need the full 3 minutes. Again, this is 3C. And Mary and Dan, please feel free also to chime in too if you have ideas. Or Dr. Reader. So maybe another minute.
I can't access the chat, but one thing that I wanted to bring up was like some things people do is maybe after like a week of adhering to their PrEP medication, they might give themselves like a small reward, like they could eat a cookie they really like. It would be an example of a concept.
Okay. Again, if you want to answer, it's under Q&A. It's like you click on answer live and see a lot of great responses coming in. I'm really excited hearing about all these different ways that people are using behavioral economics in their life. Okay, so maybe about another 15 seconds and we will look at the responses. Dr. Reader, would you like to read them or would you like me to read them?
I can read them. I kind of figured out what was happening with my computer, so I apologize for that delay.
Oh, it's no problem.
So some of the responses that came through for 3C, client check in for accountability, stages of change model, daily life use, making choices to cue, help friends to create cues to be used successfully, took away a leadership role until I can show is acting responsibly with sexual choices. When I was a disease intervention specialist, convincing individuals to get tested because they were possibly exposed to HIV could prove to be challenging, primarily out of fear. There's a peer educator for Philly Fighter using my daily presentation. Okay, that's not part of the question answer. I think being creative with clients about how to keep themselves safe and create routine for their sex safety. And that was the last response for question 3C.
Yeah, and there's another, someone asked if they had asked a question, if I saw the question. I know we're going to try to take the questions at the end.
That's the first one at the top. So I was waiting to the end to answer that question.
Oh, I see. Okay. So my question is that as we, as clinicians, discuss with clients who are taking PrEP is that they're not immune to other STDs. I found many clients think they are taking PrEP if they're immune to other diseases. And I think that's also very important. I mean, to realize that, you know, how we're speaking to patients or clients, actually maybe very careful about the information that we're giving them. Dan, do you have any, Dan actually is a medical student. I'm not sure if you might have some additional words about this.
Yeah, I think it's, I think that's an interesting question. And I think more from kind of knowing the literature, I think there's kind of mixed literature about, you know, some people continue to be very concerned about STDs and, you know, maintain kind of the same sexual, you know, the same sexual health practices that they used before getting on PrEP, and other people might not be. And I think one thing that could be, you know, kind of using a behavioral economics thought process to this, you know, how can we help people both establish that routine to taking PrEP, but also kind of maintain or establish routines for, you know, wearing condoms or taking other steps to protect themselves from other STDs, if that is kind of in their best interest. I certainly think that there is an argument to be made that if we are able to facilitate the routine formation of taking PrEP, like, then we kind of should pat ourselves on the back and because that is a major part of people's sexual health, but that doesn't mean that one routine has to, or one habit really has to replace another habit. And we can kind of try to facilitate both.
And I also wanted to add in the project we did that Deborah might talk about a little bit after this, where we actually interviewed some people who take PrEP and were looked in other literature, and people did say that one reason they decided to stop taking PrEP was because they either got another STD, or they were worried about that, or worried that they wouldn't use condoms. So I think that's definitely a good concern and great question you brought up. So one thing I think when getting a prescription, there should always be that disclaimer that this is what it does. It's just for HIV, and you have, if you're gonna still engage in other behaviors, to be mindful of all of that.
Well, great, thank you. Thanks for the question. So we can go to the next slide. All right. So the goal of today's workshop was to bring people together from all aspects of HIV prevention to brainstorm ways to incorporate behavioral economics concepts into daily life or work routines. So prior to the pandemic, we imagined hosting a lively discussion, which would have resulted in ideas that we could all take home with us and we could try incorporating them right away. So in lieu of an in-person discussion and respecting the limitations of the technology that we have today, we'd first like to tell you about our Nudge project from last year's behavioral economics class. And then we're going to brainstorm some ideas together using the Q&A feature, and the moderator will help us with this as well. So, and Mary has alluded to this, but one of the goals of the class that we were all in was to design an intervention, either a clinical, public health, or policy intervention that addresses identified bottlenecks using behavioral economics. And this was our Nudge project. And Mary's already introduced the concept of Nudge based on the Nudge framework. So that was narrow, understand, discover, generate, and evaluate. So students were asked to select a health behavior and complete a set of structured assignments to narrow the behavioral target. We were then asked to understand the context through inquiry, distill or discover behavioral insights about behaviors to the target behavior, and also generate intervention designs to address those behaviors. Our group was comprised of students interested in HIV prevention. That's how we found each other in the class. And we were also all interested in working on a project related to PrEP adherence. And also we were interested in the idea of maybe implementing a tool such as an app to improve PrEP adherence. That's how we found each other. Next slide. So after narrowing the behavioral target, which is the first part of the Nudge framework, we decided to address the following problem statement. Some men who have sex with men don't adhere to taking PrEP. We felt that focusing on this problem statement would have the highest potential impact, with the possibility of a distinctly measured outcome and existing channels for intervention. We felt this would provide an opportunity to address the problem through individual behavioral modification, as opposed to requiring structural changes in policy and society. Additionally, the problem statement allows for many potential intervention points at which at-risk individuals can be reached by providers, specialized clinics, and advocacy organizations. Next slide. As mentioned, this was a Nudge project, and so we were asked to narrow, understand, distill or discover, generate, and then evaluate. During the understand assignment, we engaged in a contextual inquiry and collected data through target population interviews, healthcare provider interviews, literature review, and we reviewed patient perspectives that we found on social media, YouTube videos, and TED Talks. Essentially, this part of the exercise was just to get the lay of the land, figure out what's going on in this question related to this question. This inquiry revealed diverse and unexpected insights into the topic of PrEP adherence. Both patients and clinicians directly reported high PrEP adherence, and this may have been just possibly due to the fact that when we selected our interviews, we were selecting people that might have been more highly motivated and more aware of what was going on, simply because we're in the same sphere. And although we interviewed relatively adherent populations, we were able to identify potential channels related to adherence through other sources. For example, conversations posted on Reddit provided insights that were also invaluable to our inquiry, and PrEP users on Reddit shared additional barriers to adherence that were not explicitly mentioned in the literature review or the interviews. So we did get a diverse set of responses to this inquiry. Next slide, please. So in the next part of our project, Distill or Discover, we identified 5 main behavioral hypotheses that were barriers and channels that possibly increase the intention to adhere or the actual adherence to PrEP. And so I just wanted to share with you some of these 5 areas. Number 1, PrEP adherence is higher when taking PrEP as part of individual's daily routine. We've already talked about that some today, and some of the concepts that we have already discussed, like habit formation, play a key role in adherence for PrEP. Dan talked about JD, who puts his medications next to in a certain part of his bathroom possibly, so that he remembers to take them, or we talked about putting your gym bag certain places so you remember to go to the gym. So habit formation is a really important part. PrEP users with a high adherence form the habits of taking PrEP by connecting the action of PrEP to other areas of their daily routine. The action of taking PrEP was also made more salient for some PrEP users who incorporated PrEP by using reminder alarms or placing the pill box on a shelf with other morning necessities. On the other hand, PrEP users also, with low adherence often experience hassle factors and planning fallacy around the action of taking PrEP because it was not incorporated into their daily routine. Number 2, periods of not engaging in risky behavior are associated with lower PrEP adherence. And Dan also mentioned that as well, especially during like COVID, where people may possibly be at home more and not engaging in risky behavior. During low risk periods, the salience surrounding the importance of adhering to PrEP for HIV decreases and present bias kicks in. At this time, some men who have sex with men may experience optimism bias around how low their actual HIV risk is. Although PrEP may seem unnecessary during low risk periods, they may also experience hot-cold empathy gap when they stop taking the prescription as directed, and risky behavior is often unpredictable, and they need to be prepared for these encounters. Also, another way of looking at it, though, is that maybe another channel would be that taking PrEP daily reassures protection during sexual encounters, no matter how episodic these encounters are. And this attitude may counteract optimism and present bias even during lower risk periods. Number 3, it's difficult to attend recurring appointments for blood work. So PrEP users are required to get blood work to test organ function and HIV status every 3 to 6 months. There are a few cognitive biases that may hinder this important step required for PrEP adherence. And this obviously, I think what jumps out is hassle factors. A lot of us even, who wants to, make an appointment to see your doctor on a regular basis, especially if you're young. Many PrEP users are healthy adults and not used to frequent medical appointments. Getting to an appointment every 3 months can be difficult and may result in missing appointments or having to reschedule your appointment. And also, planning fallacy also comes up in this, related to this hypothesis. At the same time, receiving frequent confirmation of your HIV negative status and lack of side effects actually may be reassuring and may actually increase PrEP adherence. So that's another idea that might be related to that. Number 4, social support increases PrEP adherence. So when I think of social support, I think of social norms, and that PrEP might be considered a social norm. Users may be more likely to adhere to it if they're getting support from their partners and other people around them who are supportive of using PrEP. So support from counselors is also associated with higher PrEP adherence. Social support is important for continued PrEP adherence for several reasons, including increased salience of HIV risk and increased social acceptability of taking PrEP. By leveraging technology, for example, and creating a social support network for PrEP users, it may be possible to increase adherence for those who are otherwise not aware of support. So finally, we thought about communication with healthcare providers as an important factor of PrEP adherence. So open communication about side effects and benefits of PrEP with a healthcare provider can help PrEP users adhere to treatment. We found mentions of experience and potential side effects that could deter PrEP adherence. One Reddit post described a PrEP user experiencing side effects, spoke with their doctor, and the doctor helped him arrive at a solution to help mitigate these side effects. And after that, he experienced no further side effects once restarting his medication. So engaging in open communication with his doctor made his concerns about the side effects salient to his doctor and led to his long-term adherence. On the other side, PrEP users that don't openly communicate may discontinue PrEP. One former user that we came across stopped using PrEP after a pharmacy technician explained potential side effects that his primary care doctor had not warned him about. So possibly technology could be an intervention used to foster a dialogue between patients and providers to help mitigate these concerns about side effects. And this would also reduce the hassle factor of having to search online for your own answers, which could obviously lead to the wrong information. The next page. The next part of our project was to generate some ideas. And we came up with several ideas, and I just sort of summarize them on this slide. For example, these are intervention ideas. For example, a PrEP adherence checklist. Another idea would be to like take advantage of something like Grindr, which is already in use, and possibly incorporate some PrEP adherence reminders into an already existing app. We thought about text messaging program to help remind people to take PrEP or to go see their doctor. Another idea we have possibly is maybe somehow integrating these reminders to take PrEP into adult media, for example, like pornography or other types of adult media. So obviously, I can't talk about all of them today, but I want to tell you about the PrEP adherence checklist. So this is an idea, and again, what we're showing you now is not an official checklist, but we wanted to illustrate for our instructor, like what we were talking about, that it would be something like, as shown on the screen, that, so this would be aimed at men who have sex with men or who have already obtained a PrEP prescription. And this would be an adherence counseling intervention that would begin at the time the prescription is written. In the healthcare provider's office, the patient would be offered free adherence counseling at the time of initial prescription. Or if you're already a veteran user, you'd get counseling to help continue your adherence. So this checklist would be designed to address the daily routine barrier to PrEP adherence. So some things that would be covered in counseling would be the importance of PrEP adherence, how to take PrEP, how to refill a prescription, potential side effects, when and how to contact the healthcare practice about problems with PrEP, the importance of and how to schedule the follow-up appointments, and also how to ensure adherence. So we thought about ways that this could be, the training could occur in the form of a scripted interaction or a video format that could be reused by the healthcare provider. So what we're trying to do in this intervention is to leverage habit formation insights, namely the need for consistency of use every day at approximately the same time each day, and the need to link PrEP use to stable context clues. So from the initial appointments, the patient will come away with understanding that of their PrEP prescription and the importance of adherence. Additionally, the patient will leave with both the customized hard copy and electronic checklist to help them formulate a plan for success. We're trying to leverage in this intervention habit formation, reducing hassle factors for adherence, and also perspective memory and planning fallacy. Habits they may form or become an issue if poor habits are created. The intervention will help the patient identify customized personal rewards for sticking to their PrEP adherence routine. During the survey portion of the counseling, where the counselor is actually talking to the patient about trying to get information about how they might incorporate PrEP into the daily routine, it will be important for the healthcare provider and patient to identify current daily reminders, such as Google Calendar, that had been successful for that patient in the past. So we're trying to work with the patient in their existing life, like how they actually remind themselves of events and how they're actually living, as Dan actually talked about earlier in his example. So that was one of our ideas, and we thought it would be relevant to this group because it's, it's one of these things that I think it's easy to access. I mean, doesn't have a lot of technology involved, and a lot of us actually might be already using checklists in our daily life or in our work setting. So we thought it would be a really good one to talk about today. But I want to also mention that some of the pros that we thought about with checklists, you may also come up with some other pros and cons as well. And I want to actually just remind you guys that Mary talked about the EAST framework. Do you remember easy, attractive, social, and timely? So some of the pros that I mentioned are related to that. Like this is a very timely intervention because the person's just coming in with a prescription. So it's a great time to sit down with them and talk to them about some of their habit formation and trying to figure out how they can actually stay adherent to PrEP. It's easy to implement. I mean, anybody can come up with a checklist. It's not expensive to do, and you can reuse it. You can create a video and have a very standard training, and it should be very easy to like introduce into a healthcare setting. And also, you can update it easily over time, so that when we actually get new knowledge about PrEP, for example, Dan talked about like the future of PrEP. As that changes, you obviously would want to update your checklist to so that it agrees with what people are really doing in real life. A con would be obviously this type of intervention would require buy-in from the providers. It also adds time to the visit, and that's one of the reasons why, you know, a provider might not be willing to give buy-in. Another thing, over time, patients may opt out of it. So we're sort of hoping that maybe when we were imagining this, that the first time you're prescribed, you would get this checklist or go through this training, and then over time, as you come in, you still would have this training accessible to you, and providers would keep pulling it out and talking about these reminders, making sure that things haven't changed in your life. However, I could see over time that patients might be into this for a while, but then the intervention effects may actually wane over time. So I think one concern about the fact that the effects may wane is that you might want to layer this intervention with other interventions. For example, opt in text messaging, or the social connections with other users, in some way that you're actually layering interventions is sort of to increase the relevance and power of this particular intervention. For example, letters from the provider might help this intervention's effects last a little bit longer. So we can go to the next. So that was basically our nudge project in a nutshell. And I was wondering if you have any questions about the presentation, but I also want to ask if you have questions about our nudge project. And also, do you have any other ideas that we could use to add to our toolbox that we've already presented? So definitely use the Q&A box at this point. We've ended the presentation portion of the webinar, and now we're opening the presentation up to questions and feedback and information that we can share. Thank you very much for attending. So definitely, so use the Q&A if there are any additional questions or thoughts. So I'll give you a few minutes a couple minutes to write some comments. I see some coming in. Dan and Mary, are you also able to see the Q&A box?
Yep, we can see it. And it looks like our monitor's screen froze, so we can read out some of the questions.
Oh, okay.
I personally can't see the Q&A, I think because my screen is shared, but, and also if there are any questions from before.
You're also, you can also unshare the screen at this point.
But I'll scan through some questions now.
Yeah, but keep putting them into the Q&A box, because this is really why we want to do this workshop, so we could talk to you guys.
So one idea, we have some praise for our presentation, so thank you for that. And also one comment that was interesting, I think this could be something to add to our toolbox, was someone said I have passed out many pill keychains for clients, so it's helpful to have an extra with you at all times just in case. And one question here is, like, why did we decide, why is like PrEP stressed but not condom use? So I guess like maybe why we decided to focus on PrEP. Either of you want to take that over, or I can share my own thoughts on that. We, like, for this, we know HIV prevention has like so many different steps, and we think like condom use is definitely important because it can protect against a lot of things. But people are like more resistant to condoms. There's more issues, and like you have to navigate with your partner too with wearing a condom, while PrEP is like a more personal thing. So we thought in this behavioral economic framework, PrEP adherence was something easier to focus on, but condom use is very important. Can also use a lot of behavioral economic frameworks with that. It just takes the other step of like having to like, I guess PrEP also includes having to buy one, but like having to go out there, make sure you always have it on you because it's something you use in the moment rather than just something you could do at the beginning of the day and make it a habit. And like I said before, sometimes partner negotiations don't always work the way they should. Let's see.
Yeah,
Go ahead.
And I think Mary said it absolutely right. And I think the other thing is, we to kind of do this nudge project, I feel like successfully, we really wanted to like hone in on one specific thing, because if we choose a couple different barriers or a couple different kind of behaviors, like both PrEP and condoms, they might have different barriers or drawbacks, which makes it harder to kind of design to generate these ideas. But that, like Mary was saying, this isn't to suggest that behavioral economics couldn't be used. Things like how to overcome planning fallacy, how to overcome present bias. There are other tools to use that could be appropriate for like assuring condom use.
All right. And another great question we have is, behavioral economics seems like it is a great way to assess decision-making processes and develop interventions. However, how can we ensure that service providers using this method don't apply judgment, moralize, or further stigmatize the behavior? Any thoughts, either of you?
I think that's a wonderful question, and I'm curious to hear what Deborah and Mary say. I think the one thing that hopefully behavioral economics emphasizes is that all of these kind of challenges that we face are absolutely human challenges, and they're like innate to like our species and not to a particular person. And some people might be more present bias than others. Some people might have more optimism bias than others. Some people might have kind of more of a hot-cold empathy gap than others, but all of these are very human challenges. So someone who's struggling with kind of, adhering to a daily medication or to using a condom, like that's no indication of like them as an individual, just kind of they're struggling with things that we all do. And I think trying to emphasize the universality of this is one potential way.
Yeah, I agree that as Mary mentioned in her presentation, that behavioral economics is really about although the definition talked about like the human limitations, it's really about being human. All of us experience these biases. These are actually very real. I mean, no matter how well educated or the person's in a position that they're a medical doctor or a nurse, they also have struggling with the same types of biases that everybody else is. So and actually that's really important to recognize that what we're trying to do is come up with ideas that might meet people where they are, like acknowledging that we are human. However, I definitely see how it could be used in a very discriminatory way in a sense, because if you're assuming that a person's not going to do something for a certain reason, that could also be very unfair as well. So that's definitely a challenge that I think people who are using some of these tools, or if they're making assumptions about why someone's doing something or not doing something, they have to be very careful and be very, and maybe that might mean like, if you're actually going to roll out intervention, that you've vetted it with other people in the organization and other community leaders, just to make sure that you're not making assumptions that actually would hurt people in the long run or undervalue their opinion or their lifestyles. The goal is to not try to assume that everybody is going to act in their best interest all the time, and to understand that none of us do, and trying to figure out ways to give people some options. And I think, for example, the checklist was an example of, if used correctly, the healthcare provider would be talking and engaging with the participant or patient, and they would be making decisions together based on the participant's or patient's lifestyle. These are just like, this is just a tool, and I'm asking you, how can you see yourself using this checklist? And the patient is actually guiding it. We're just providing the tool.
And so like, thank you for, I think that was a great answer to that, and definitely like a lot to think about in any kind of patient care. We have to make sure we don't ever stigmatize a person or like the behavior they're engaging in, just try to like gear them towards what, even though we might have different views on what we think is healthier, but try to get them to make the best decision for themselves using this framework. And we also, so we have a few more questions that came in, and sorry, my dog is barking now because I locked him up and so he wouldn't run around. But these two can kind of be combined. One is like, what are the financial barriers? Like, is insurance coverage good? And another that goes with this is if people received medication for free, so if there was no cost at the point of sale, could that prompt long-lasting behavior change? And I think so. Like Dan, you can correct me if I'm wrong, but a lot of states now, like, PrEP is free, even sometimes even without insurance, or you can get like a credit for it. So there are like, and not everywhere, a lot of like this, it's on like more a local level rather than federal level, but people do have access to PrEP and other HIV prevention strategies. So so that would, like, the financial aspect is more of a structural barrier, but even once that's removed, people still have trouble adhering to the PrEP. So I think it definitely, like, if it was free, it could be for everyone and easy access. We could get it easy at a pharmacy. More people might take it or like opt into taking it, but once you actually like have the pill at home, there are these other behavioral barriers that could still get in the way of you taking it, which is kind of what we addressed here.
I think we addressed all of the questions. There was a question about not being able to see the comments and questions. I think we've read them all. So hopefully, because I think I do agree that, you know, it'd be nice to hear directly from everybody what their questions are. Hopefully we have read them out. There's also a question about a certificate of completion and access to the slides. I think we're going to try to, oh, hello.
Hello, hi. So I actually work with Dr. Reeder. She promoted me to panel. She was having some technical difficulties on the back end. So I just want to thank you all for handling those questions and answers so artfully and really well. I was watching as a participant. This was a really great presentation.
Oh,
so
great.
Thank you.
Thank you. And just remember, we're students too, so we're just really trying to learn, and we just wanted to share what we found interesting about the course. And I think it's really great. For example, like the course was last year, but we're still working together on this project, and it's really excited about it still. So any feedback you have, for example, about the Nudge project that we discussed, any other questions you have about it, you can also ask that now as well. Or anything else. We can't necessarily answer all questions. We're not experts, but we can definitely maybe even raise them to discussion from other people, or we could even think about them and come back, possibly.
So it looks like someone wants to bring the Nudge project to their team, and additionally, someone said they really appreciated the framework, and it's neat to hear about your collaboration. So thank you. I think this is a really inventive and really like accessible framework that can be applied to a lot of different studies. So I'm just speaking from what I've consumed from the presentation and as a public health professional. So thank you. And that question about stigmatizing and moralizing was me. So I just wanted to thank you for that great response. So thank you. If anyone else has any further questions, please keep them coming in. Cool, so we have one question. Was your project based on the stages of change model?
I think that's a great question. And so it wasn't direct, and I'm guessing by stages of change, the person's referring to like the pre-contemplation, contemplation, I believe the next is like planning, and then it's a cycle. And I think there's a lot of overlap between these. One of the things that behavioral economics really relies on is insights from psychology and behavioral sciences in general. So I'll say directly, like we didn't consider directly the stages of change in our project, but it's there are a lot of overlaps, and certainly behavioral economists who do this for a living certainly are very familiar with things like the stages of change and like the taxonomy of behavior change techniques and kind of these different insights from behavioral sciences and kind of try to integrate them more thoroughly into their intervention designs.
And I think one overlap that like especially like connects between that is when we get to the narrow stage, when we're choosing which population to focus on, that could kind of be like what in the stage of change, like how ready someone is to change. So like we decided to focus on PrEP adherence, which means it's someone who already learned about PrEP somewhere, was able to go to a doctor already and get a prescription. So like there's definitely a lot more steps even leading up to that stage. But when we narrowed down our problem, we focused like initially on people who already were motivated to take PrEP, but maybe didn't always adhere to it.
So not the total model, but like maybe steps within the model. Question, how does someone become a behavior economist? That seems like a pretty cool profession.
That's definitely a good point. Like you can see, like we all have very different backgrounds. I am studying communication. We have like med student, and Deborah's background is epidemiology along with some other things. So it's like, there definitely are, I think, people who do go to school specifically for behavioral economics. But a lot of times it's, like it's like how it's intersect between psychology and economists. A lot of times they come together, and it's not only applied in the public health domain, it's applied to like any kind of decision making. So yeah, I don't know if either of you have any other thoughts on that.
The important part is that like, I do, my degree is in epidemiology, and I've worked as an epidemiologist for a long time, 20 years. And I really had no concept of behavioral economics before I started working in the department. And I'm in medical ethics and health policy as a project manager, and I'm also in the Center for Health Incentives and Behavioral Economics. And I was like, wow, what is this? What am I working in? So I've really enjoyed learning about behavioral economics, and I see how I've already been doing these things. I mean, all of us have been doing this stuff. We just didn't know the terminology or the jargon. And so I understand there's a whole field of science around it, and it's based on psychology. When I talk to my friends who are psychology professors, they know what I'm talking about. They maybe use different terms, but it's all related. And it was actually kind of reassuring to understand that people are studying this, and it's actually a field of science. So I would think to get started, you would just start learning about the terminology and acknowledging where you're already using it and how you're already using it. And also thinking about ways that you could incorporate it into your daily work routine or daily routine. So I don't think I think it's very accessible. Again, I was surprised. I already kind of knew what these things were. I just didn't know what the terminology was. I felt like I was kind of halfway there.
Another thing I wanted to add to, I think, one question we did not totally answer yet, but someone who asked if they would get a certificate and access to the slides. So, I'll let to that. But like, if we are able to pass on something electronic later, one thing we might put together in addition with this is like we could suggest books to read or other things that might help people learn more about it. But I will let Kyle answer more specifically how that will work.
Absolutely. So really it's case-by-case basis depending on how the presenters want to communicate their work post. We do have a post-webinar survey that we send out, but we will be more than happy to kind of be the conduits of further information from you all. We'd be more than happy to send out further information and connect you with anyone that wants to learn more about this. So whatever you have, you can send to either Dr. Reeder or myself, and we'll get that to our participants. And we can pull all the viewers' kind of information from the back end. So the folks who register, we can get them anything else. In addition to a certificate of participation, which we will facilitate that process as well. So, we really want to thank everyone for coming on today. It's really, I always say a webinar presents a unique set of challenges on a normal day. These times I think are extraordinary, with the convergence of a public health crisis, civil unrest, and I think we had a tornado the other day. So let's just all name that and uplift that, and that we're all trying to work during these times. So I just wanted to thank all of the people in attendance. And especially I wanted to thank the presenters. So I apologize for not putting on a shirt with buttons. I did not anticipate being on today, but I just wanted to thank you all for working with us today. And
it was so much fun. This time passed so quickly. I really appreciate you inviting us to do this. And, it's really exciting to be able to take a class and then share the knowledge of the class with other people and get feedback on it.
Knowledge is power, and we add sedimentary layers of more knowledge when we share it and hear feedback. So I think it's great. So some more people are just saying this was a really great presentation, and someone mentioned that they welcome slides and further resources.
Oh,
So
definitely on that. Thank you.
yeah, yeah. So if anyone has any further questions, this is your last few moments to ask them. And to the presenters, do you have any closing statements?
Just thank you for coming and listening to us. And I hope that you can take some of these things that we've mentioned and incorporate them. And we'd love to hear how you've done that, actually. So, Dan, do you have anything or Mary?
I want to reiterate what I said before, how like behavioral economics is not a substitute to big structural change that needs to happen. So like keep fighting on that level, on the policy level, to get people like the healthcare they need. But I hope I hope like you can use these tools, and we'll definitely, however communication works in the back end of this, share our slides and other further resources that you can implement into your own life.
Great, thank you.
Absolutely. And with that, everyone, thank you for coming today. And don't forget, the AIDS Education Month continues next Monday with a 2020 vision. It's time they see us. So we look forward to seeing you next Monday, and have a good day, everyone, and have a good Friday, and be well to yourselves.